Okay, your national manager, health promotion, Marine Government.
Thank you.
Okay. Yeah, so that's what we'll do. We'll give you about 5 minutes, and after that, Dr. Hoosen will do the presentation.
Awesome.
Okay.
Thank you so much. Hi, Dr. Hoosen. Good luck.
Hi, thanks, sister. Thanks, sister.
Yeah, I believe you've got until 7, Dr. Hoosen.
Okay, yes, I just got till 7. I've kept my talk as concise as possible, but with as much detail as I should share to your audience, and left enough time for questions as well. Questions
Okay, that's fine. Yeah, yeah, we know about that. Depends on the participation of the audience. You know, sometimes they go long. Last week they were quite engaging, but it was about something that affects them on a day-to-day basis, about putting of debts. But it's fine.
Yeah, so Dr. Billa, what we can do, if there are still questions, people can always get through to Cancer's help desk. They can send the questions through there, and then I can send it to Dr. Hoosen, and we can give them.
Oh, that's fine. Yeah. Okay, I think we'll let the people. Are you just going to talk? You're not going to do a presentation, Lorraine? Hi, Lorraine. You're just going to give a talk. You're not going to do a presentation.
I have about 3 slides, so it'll be quick.
Then I think we should load them so that Kamo can check if they're working well.
Okay.
Can
I share my screen?
Give Lorraine a presentation rights, Kamo?
Yes, she can share doc, and I've also let people in.
Okay, that's fine. You'll tell me when we are ready to go.
Yes, we are good to go.
Okay, thanks. Good evening, colleagues, and welcome to our weekly webinars hosted by Clinics Health Group. And we are glad that you're always able to join us on a weekly basis. My name is Raymond Bill. I'm the Group Medical Officer for Clinics Health Group. We are based in Johannesburg. My head office in Hyde Park, but we've got hospitals across Johannesburg and the south of Gauteng, and also in Pretoria, and also a hospital in Mahikeng. And this evening, we are excited to host you once more. But please do note that these webinars are CPD accredited, and we're also streaming live on YouTube. So at the end of the presentation, if you want to look at this presentation, you're at liberty to do so at your leisure. Yeah, but just like us on YouTube, Clinics webinars, and you'll be able to see all the previous and the current presentations. We are not going to be showing our slides for clinics this evening because we've got a very tight program. And so this evening, before we do the presentation by the guest speaker, we're going to be talking a little bit about the Cancer Association of South Africa, led by Ms. Lorraine Govender, who's the National Manager for Health Promotion in Cancer. So I'm going to ask her to do a short presentation, and thereafter then we'll then go straight into a presentation by Dr. Siddeeq Hoosen, who's our guest speaker this evening. Please always remember to mute yourselves and switch off your videos so that we enhance the quality of sound and reception for these webinars. Thank you a lot, and welcome, Lorraine. Thanks for having you this evening.
Hey.
How are we?
Good evening, Dr. Billa, and everyone that's connected here this evening. Thank you for the opportunity to present. I'm just going to put my video off and talk through the slides. So the Cancer Association of South Africa, we are a national organization. Sorry, I'm just going to, there seems to be a problem with my slides. Just going to share again. Oh, see.
You can share again, and Kam will help you. I'm learning now, but it says put the cursor anywhere on the slide and click next.
Okay.
It will work. I'm learning. You share again.
Okay, I'm trying. It's just that my slides don't want to move, but
Yeah, that's what I'm saying. Yeah, if you just share and then
I'm just going to go through it this way for the purpose of time. I don't want to.
I can do the slide presentation and just come with Jan. Can you tell Lori what to do? Go to slide presentation, slideshow.
Sorry, I think there's a problem with sharing the screens because my slides are not moving.
There
we go. Okay, I'm going to show it this way if everyone's okay with it.
Okay, no, that's fine. That's fine, Lorraine.
Okay, thank you so much. So the Cancer Association is focused on 3 pillars, which is research, educate, and support. So our comprehensive research programs help us to look at how we want to support the different programs that we run. So we have our health programs and also our care and support programs, including an advocacy angle. So we educate the public on how to lower your cancer risk. And we also promote health and awareness and offer care and support to all our cancer survivors and their loved ones. So the next slide just, I think there's a problem. The next slide just shows you some of the services that we provide in terms of reducing our cancer risk. That's mainly based on the education and awareness component. And then our support programs look at the top cancers that is affecting our country, and we look at how can we educate and support patients and survivors through those programs. I have a little slide here as well, in a small infographic that talks about the multiple myeloma program, and Dr. Hoosen will talk more about it later on. We also have a dedicated cancer help desk where we have staff that man the telephone lines as well as a WhatsApp group. And interesting to note, it is also available in other languages. So if you look at our cancer toll-free number, it's 0800 22 6622. And if you want to email us, this address is also available. And Dr. Bella has mentioned that he's going to show this is going to also be available as a slideshow later on. My next slide then talks about the cancer care homes. These care homes are based throughout the metropolitan areas nationwide. We have 8 care homes countrywide, and they provide comfort to our patients. We only take patients who are able to take care of themselves, and we offer accommodation to these patients who are undergoing cancer treatment at various oncology clinics, which is often far away from their homes. They are able to stay for between 4 to 6 weeks. They receive meals and transport to and from the care homes. The next slide is extremely important, and I want all our clinicians and everyone that's available to please pay attention to this slide, because, you know, a cancer diagnosis is often quite an emotional impact both to patients and to families. So our Connect to Hope is our telecounseling line that is available, as you can see, in 7 languages. And people can call through our toll-free line and book an appointment if you need care and support. It's not only for patients, but also to the caregivers. This is just our Tough Living with Cancer program that aims at supporting children and also our adolescents that are affected by cancer. Advocacy forms an important role in cancer. So we often know patients who are affected by cancer usually do not feel right emotionally to be able to talk about their problems. But our advocacy department in cancer is there to help the patients with their rights and to health care. My last slide is here just talking about the online support programs that we have. As you know, because we are a national organization, we're not able to be available all over and in every province and every community, but our online support programs are important in helping both patients and families. But thank you, Dr. Bila. I will now hand it back to you. Thank you.
Thank you very much, Lorraine. I see you're trying to rush the presentation. But we want to just want to thank you. I think at least the slides are captured. You can also share them with us. You can share the slides if it's okay with you, with all the participants who have logged in here. So if you just send me those slides once more, then we'll share them with everyone who's logged in so they can have information about how to contact the Cancer Association of South Africa and yourself in particular as the National Manager, Health Promotion. And we also want to thank the Cancer Association for helping us to get the speaker this evening, who is none other than Dr. Siddeeq Hoosen, who is a senior pathologist in the Department of Hematology and also in NHLS at the Joint Staff at the University of KwaZulu-Natal. He's been there since 2009. He did his subspecialization after obtaining his BCHB in clinical hematology in 2018 and is currently the acting head of clinical unit for the Department of Clinical Hematology based at King Edward VIII in Durban. This hospital is the referral center for all chronic hematological malignancies and benign hematological disorders in KwaZulu-Natal. And so we are quite excited to have you, Dr. Hoosen, all the way from Durban to speak to us this evening on multiple myeloma, an approach and basic management. You've got quite a number of participants. We get one of the record attendances that we have, which shows that indeed this is an important topic that we need to cover this evening. And so we are glad to have you this evening. Thanks.
Thank you so much, Dr. Vila, for this opportunity to speak, and thank you to the audience for joining. Just let me know if you can hear me loud and clear and whether you can see my screen.
Yeah, we can hear you clear. Maybe just one picture, just once, so that you know that you, and then you can switch off your video just for a minute, and then you can switch off.
Okay. Good evening. Good evening to everyone, and thank you so much for joining us and giving me this opportunity to speak on this platform. I'm going to put my screen off now.
We just saw a blank picture. We didn't see your face at all.
Oh, I'm not sure if there's a problem with my camera. Sorry about that.
Yeah, perhaps. Yes, okay. That's fine. Okay.
Should I go ahead?
Yeah, go ahead, please.
Okay. Thank you so much. Okay, so tonight we're going to be discussing multiple myeloma, and multiple myeloma is a very complex topic, but I try to simplify it as much as possible. I believe you have a very diverse audience, and so we're going to speak about approach and basic management. Okay, so this is an overview of my talk. I'm going to start off by introducing hematopoiesis and going to describe to you the role of antigen-antibody interaction in terms of the development of the plasma cell. We'll just go through that very basically. It's going back to a lot of basic sciences. Then we will define and discuss the criteria for the diagnosis of multiple myeloma, the presentation of patients with multiple myeloma, and then we will discuss the approach of a general practitioner, in terms of these type of patients. We will discuss the specific investigations. We will discuss emergencies, treatment, which is, again, something that may be beyond this, the scope of this particular talk, but we'll touch on that as well. And we discuss management in general in the form of a multidisciplinary team. And the last slide, for those who join a little late, we try and just catch up whatever you must. Okay, so hematological malignancies affect blood, bone marrow, and lymph nodes, and very broadly categorized as either leukemia or lymphoma. They can be further subdivided into acute and chronic forms, as well as according to the lineage. So you get myeloid malignancies and lymphoid malignancies. And approximately 9% of all malignancies were actually hematological diagnosed in the US in 2017. So on this, in this cartoon, I just want to go quickly through the development of the stem cells right down to the the mature cells. So you can see it's divided into bone marrow as well as blood and tissue cells. We have the pluripotential or multipotential hematopoietic stem cell, which at a very early stage differentiates either into a common myeloid progenitor or common lymphoid progenitor. So from the myeloid lineage, you get 3 cells that emanate. It's your megakaryocytes, which then mature in the form of platelets in the peripheral blood. The erythrocytes, which develop from the normoblastic, the erythroblasts, and then mature to erythrocytes. And then myeloblasts, which most of us will probably be familiar with in the form of neutrophils, eosinophils, basophils, and monocytes in the peripheral blood. In terms of the lymphoid lineage, these differentiate either into natural killer cells or small lymphocytes, which further subdivide or further subtype in the form of T or B lymphocytes, and B lymphocytes eventually mature to a plasma cell. So in terms of hematological malignancies, we can see that essential thrombocytosis is the disease that's associated with clonal expansion of a malignant clone in the megakaryocytic lineage. There are other tumors, but just in terms of just to keep it as simple as possible, we just go through some of the common disorders. Polycythemia rubra vera develops from the erythroid lineage, and chronic myeloid leukemia from the granulocytic lineage. Acute myeloid leukemia, again, this occurs at a myeloblastic level where you have mutations in the myeloblasts, the development of acute myeloid leukemia. The acute lymphoblastic leukemias actually emanate from the common lymphoid progenitors and then subtype into B or T lymphocytes. And we see the more mature lymphocytes, if they develop a clonal expansion, we get lymphoma. And so the topic of our discussion today is multiple myeloma, and this disease emanates from a clonal expansion of plasma cells. Okay, so what is multiple myeloma? It is a hematological malignancy that arises from plasma cells and is broadly categorized under the subdivision of lymphoid malignancies referred to as plasma cell dyscrasias, and pathological plasma cells with expansion result in destruction of organs and systems. And this is what a plasma cell looks like in the bone marrow, or sometimes we do see it circulating in the peripheral blood, very unusual. In terms of the prevalence, or rather the multiple myeloma is probably the second most common hematological malignancy after diffuse large B-cell lymphoma. And probably a lot of you may have encountered patients in our country with diffuse large B-cell lymphoma, especially because of its relation with HIV. In terms of multiple myeloma, the incidence is approximately 2.3 per 100,000 population, and it has a male predominance of a ratio of 1.5 to 1. And we see in the first world, the age of presentation is roughly around the 6th to 7th decade, averaging around the age of 69. However, that's a lot lower in Africa. And these are studies that were done in Ghana. Our own experience as well is that we have a much younger population, and we will discuss a little later, there is some link between HIV and multiple myeloma, although multiple myeloma is not an age-defining condition. In terms of ethnicity, we find that it is more common in patients of African origin, more than patients of Asian origin and Caucasians. In fact, there's a twofold difference between patients presenting with multiple myeloma in the African population as compared to the Caucasian population. Okay, so what is a plasma cell? Plasma cells arise from the B-cell lymphocytic lineage, as we had shown in the earlier slide, and they are found in bone marrow as well as in tissue fluid. Primarily, they are associated with humoral immunity. The humor refers to fluid, and plasma cells secrete antibodies, or rather, more specifically referred to as immunoglobulins, which is a glycoprotein. And there are 5 classes of immunoglobulins. We see the IgG, IgA, IgD, IgM, and IgE. These immunoglobulins actually are very specific to particular pathogens that the body may be exposed to, and is directed against bacteria and viruses. So we can see here in a physiological state, plasma cells that would encounter, and we're going to discuss exactly how plasma cells develop antibodies. We can see these plasma cells may be exposed to a certain pathogen, and then antibodies, polyclonal antibodies, are directed against those pathogens. However, in multiple myeloma, we see there's a pathological plasma cell, which then secretes a monoclonal antibody which unfortunately is directed at cells. Okay, so just to put it into perspective, very simply, we have an antigen-presenting cell that, for example, a macrophage or a dendritic cell that would endocytose a pathogen and would present antigen to a T cell. This particular type of immunity is referred to as cellular immunity. However, there is a communication between T cells and B cells, and we see the antigen is then presented to the B cells, which then develop antibodies that are directed against that specific pathogen. This is referred to as humoral immunity. Okay, so by definition, multiple myeloma is we find pathological plasma cells that secrete monoclonal proteins. These plasma cells proliferate in the bone marrow, which leads to bone marrow infiltration, resulting in fractures, pathological fractures, especially the vertebra, as well as hypercalcemia because of infiltration of the bone, and specifically lytic lesions of the bone. Patients can then present with pain of the bone. They may present with neuropathy and myelopathy, especially if there's fractures or there's pathology in the spine. You have monoclonal protein that's directed against the kidneys that cause renal damage, anemia, and immunosuppression. And this immunosuppression we'll just discuss in the next slide results in recurrent infections. So the specific criteria, and this was the old criteria of diagnosis of multiple myeloma, was referred to as the CRAB criteria. To put it very simply, this acronym refers to C stands for, rather represents hypercalcemia, the R refers to the renal pathology, the A to the anemia, and B refers to the bony myeloma disease or lytic lesions that we see commonly in certain structures, certain parts of the anatomy. The classical, what we refer to as the pepper pot sign that we see in the skull, is actually lytic lesions of the skull bone. Okay, so just go back a step and speak about monoclonal proteins. So if we can remember back from physiology, which may have been many years back, but if you remember the protein in the body, in the normal serum protein electrophoresis along a isoelectric current, we see it separates into albumin, which is the major part of the protein in the body, and then we get alpha-1, alpha-2 beta, and gamma globulins. When there's a clonal process or there's pathological plasma cells, we find that there is a monoclonal peak or gamma globulin spike in this protein electrophoresis. And one can see this in this electrophoresis strip here, where you see there's a darkening in the early gamma region. And this usually signifies a monoclonal protein. What then results is immune paresis, because there's suppression of one or more of the uninvolved immunoglobulins. And that's why patients are then prone to infections. One may be able to detect this by doing immunoglobulin levels, which are usually low in these patients. Okay, so what is the diagnostic criteria for multiple myeloma? First of all, we need to prove clonal plasma cells in the bone marrow greater than 10%, or a biopsy confirming a plasmacytoma. So basically, the difference, remember we mentioned that plasma cells are found both in the bone marrow as well as in tissue. So when these plasma cells, this clonal plasma cells expand in tissue, it results in the formation of a plasmacytoma, which is usually a solid tumor. And so that is the major criteria for the diagnosis of multiple myeloma, according to the revised International Myeloma Working Group criteria. We refer to the CRAB criteria. With regard to hypercalcemia, it's not just any level of hypercalcemia, but specifically a calcium level of greater than 2.75 millimoles per liter. In terms of the kidney functions, a GFR rate of less than 40 mL per minute, or serum creatinine level of greater than 170 micromoles per liter. In terms of anemia, it's usually defined by a hemoglobin of less than 10 grams per deciliter. And in terms of the bony lytic lesions or bony disease, it's defined as more than or equal to 1 lesions that is detected radiographically, either by CT scan or by PET CT scan. I must mention at this point that this used to be the old criteria for the diagnosis of multiple myeloma. However, biomarkers have actually have been introduced into the definition and the criteria for multiple myeloma. that is clonal plasma cells of greater than 60%. So in terms of biomarkers, if we find more than 60% of clonal plasma cells in the bone marrow, this signifies multiple myeloma. If there's less than 60% plasma cells and none of the criteria of CRAB, then that would not be equal to, or rather would not be a definition of multiple myeloma. Then serum-free light chains, which have become more in vogue of recent in the last 5 years, we find that a ratio of greater than 100 kappa to lambda light chains, and we will discuss this later and explain it, is also a biomarker to point towards multiple myeloma, or rather confirm the diagnosis of multiple myeloma. And now using much more sensitive techniques of whole body MRI scan, having more than one focal lesion of greater than 5 millimeters on an MRI scan would also be an inclusion criteria for multiple myeloma. Okay, so how do these patients present? So let us start off with what is very common, and that is pathological fractures. Almost 2/3 of patients present with pathological fractures. The other symptom, again related to bone, is bony pain, and this is almost in 70% of patients as well. About 1/3 of patients will present with fatigue related to the anemia or because of marrow infiltration, and 30% may be diagnosed incidentally with routine testing. Patients can present with other symptoms like nausea and vomiting. They may complain of having a foggy memory, and they may even speak about, or rather patients may present with recurrent infections. Okay, so let's going back to the specific areas or organs or systems that are involved. With bony destructions, patients present with pathological fractures. And in our experience here at King Edward, this is a very common presentation. Also, bony pain has been reported. You'll find a lot of patients who present with bony pain. The neuropathy associated with multiple myeloma is also related to bony disease. And especially with advanced disease, we find a lot of patients presenting with neuropathy because of long-standing collapse of vertebral bodies. Some patients present with myelopathy as well, and that is also a presentation that we see quite frequently in our practice. In terms of excessive immunoglobulin production and deposition, this may result in renal failure as well as amyloidosis-related symptoms, but it is less common than bony disease. Marrow infiltration, patients presenting with anemia is quite a common feature. We do see this quite often in our practice, up to about 50 to 60% of patients. Immunosuppression, patients do present with recurrent infections. And don't forget, you can get the odd patient presenting with a tumor or mass in the form of plasmacytoma confirmed by histological diagnosis. Okay, so let us speak about myeloma very generally. How would these patients present to you, and why is it important for a general practitioner to be able to recognize multiple myeloma? It was found in the UK that approximately 62% of patients presenting as an emergency actually survived at 12 months. However, 88% of patients referred for management of multiple myeloma actually survived at 12 months. So you can see that actually the general practitioner plays a very important role in the diagnosis of multiple myeloma. In fact, in the UK, approximately 50% of patients referred with multiple myeloma actually are referred by general practitioners. And this cuts down the median time in terms of first symptoms presenting to the time of being seen by a specialist. In terms of specialists, we find that only 21% of patients are referred by specialists, like, for example, orthopedic surgeons or nephrologists, or patients or specialists like neurologists. And usually there's a lag between the time of diagnosis, from the time of presentation to the time of diagnosis of almost 4 months. And the reason for this is not because specialists don't know about multiple myeloma, but rather that patients probably hop from GP to GP, looking for, trying to get down to the diagnosis until they go to a specialist and then are referred to a nephrologist. So what do we look for as a generalist? We listen to our patients. Are they complaining of bone pain, lethargy? If we do bloods, normocytic normochromic anemia, especially in the elderly, is quite a common presentation of multiple myeloma. Other cytopenias in multiple myeloma are rare, but can be found. So when do we think myeloma? In any patient with persistent unexplained pain, who is sometimes well, most of the time unwell, or anemia of unknown cause, what do we need to do? We need to perform a myeloma screen. Okay, so this is the recommendation in terms of, this is my recommendation. This is not out of any guideline in terms of screening for multiple myeloma. The first and most important thing is the hemoglobin. And the reason why we say this is they present with a normocytic chromic anemia. Maybe you would want to do a full blood count because you would like to look at the indices as well as the MCV, MCH, as well as other indices on the red cell, on the full blood count to determine, is this potentially multiple myeloma? A UNE may be a pointer. You remember patients present with renal impairment. A calcium, phosphate, magnesium is important. Calcium because patients can present with hypercalcemia, which is a common presenting feature. However, they may present with tumor lysis syndrome, and we'll discuss that a little later as a complication of multiple myeloma, and they may have hypocalcemia and hyperphosphatemia. And LFT is always a good test to have to look for an increased globulin fraction. But don't forget that HIV also, patients with HIV also have an increased globulin fraction. And ESR is also a good surrogate to point towards multiple myeloma, though it's not very specific. Then what can we do? We can do immunoglobulin levels. You can do your IgA, IgM, IgG levels. If there's any decrease in these levels, that may possibly or potentially point towards multiple myeloma. And then coming to more definitive, easy tests to perform in general practice, you could do a protein electrophoresis. And if there's any monoclonal peak, it can be identified by immunofixation. One may be able to send off urine Benz-Jones protein. And the test that I really like is the serum-free light chain. And why I say I like this test is because serum-free light chains actually helps us in our communities. We see a lot of HIV-associated multiple myeloma. And because there's an increase in globulin fraction, sometimes the protein electrophoresis can be very confusing. One may find an oligoclonal picture on a polyclonal background, which may be very difficult to decipher for multiple myeloma. One is a chronic inflammatory condition where you have multiple clones that are being produced versus a monoclonal process. And so serum-free light chains are actually very useful when it comes to HIV, and I would say particularly in our setting in South Africa. And remember, it's one of the criteria for the diagnosis of multiple myeloma according to the International Myeloma Working Group classification. Remember, I mentioned HIV is associated with multiple myeloma, and we see a lot of it. A lot of these patients are a lot younger than the that's described in the textbooks. So we find we've got a lot of young patients in our setting from experience. The youngest myeloma patient I saw was 25 years old. It's shocking to hear, but yes, we see a lot of. In fact, currently in our wards, we've got 2 40-year-old multiple myeloma patients. So how does a serum-free light chain help you? 98% of myeloma cases will have a skewed ratio. And why we say this is because, remember, in the body, kappa light chains and lambda light chains are secreted in the ratio of approximately 1.2:1 to 1.5:1. And therefore, the ratio of greater than 7 or less than 0.08 is usually an indication of multiple myeloma in 98% of the cases. One may be able to make a diagnosis of multiple myeloma by looking for a paraprotein on an SPEP, especially when it's greater than 10 grams per liter. However, non-secretory myeloma, which is a very rare form of multiple myeloma, less than 1% of cases may be missed. And so that's where a serum-free light chain is actually very beneficial. One is it's beneficial in terms of being able to distinguish between HIV-related hypogammaglobulinopathy as well as multiple myeloma. And secondly, because in HIV-positive patients, you find an increase in kappa as well as lambda light chains. And so the ratio is more important. I get a lot of calls where patients or physicians and other specialists may phone me and tell me that, listen here, I've got a patient with an increased kappa and lambda result on a serum-free light chain. And the first question I asked him, what is the ratio? So the ratio is the most important thing. And that points towards clonality. Because if there's an increased ratio, it means you've got a predominance of either kappa or lambda light chains. Okay, so specific investigations that we would perform as hematologists, or if there's physicians in the audience, would be a bone marrow biopsy. And the reason for this, remember, we said that one of the criteria is that you need at least 10% clonal plasma cells. How do we prove clonality in multiple myeloma? We do immunophenotyping, or what you may have heard of as flow cytometry, which actually picks up clonal plasma cells. These plasma cells have specific antigens on their surface which point towards clonality. They are aberrant markers. They are not commonly found on plasma cells. And then kappa and lambda light chain restriction, meaning if you're seeing a clone of plasma cells with only kappa chains or only lambda chains, that is a sign of clonality as well. One could do immunohistochemistry, which is opposed to immunophenotyping. Immunophenotyping is done on plasma, on bone marrow aspirate, and immunohistochemistry is done on a trephine biopsy. One could use the immunohistochemistry also to prove clonality. Molecular testing is particularly important in terms of myeloma management. We look at the chromosomal analysis as well as fish analysis, looking for specific mutations. And these are important to actually prognosticate patients. And therefore, we do these routinely in patients with multiple myeloma. Imaging is also very important. This can be done by a generalist as well. A simple skeletal survey of the skull, the long bones, the vertebrae and the ribs, the pelvis included, should be done if one suspects multiple myeloma. And if nothing is found and the patient is referred to a specialist, then whole body MRI or PET CT scan may be motivated for if there's a strong case of multiple myeloma. Don't forget, if patients present with a plasmacytoma or mass, then we should biopsy the mass, which could prove to be a plasmacytoma as well. Okay, so let us go through to emergencies. And the reason why I went straight to emergencies before management discussion on management is because this is what you as generalists or even other specialists may be exposed to in terms of patients presenting with either acute kidney injury directly related to myeloma disease of the kidney or tumor lysis syndrome. Patients can present with hypercalcemia to you, as well as hyperviscosity syndrome and spinal cord compression if you have an orthopod in the audience. Okay, so let us discuss tumor lysis syndrome. So what is tumor lysis syndrome? There's an electrolyte and metabolic derangement secondary to rapid cell destruction. So as these plasma cells start to break down, we find patients present with hyperkalemia, hyperphosphatemia, hypocalcemia, and severe renal failure. How do we manage this? Very simply, a patient can be given IV fluids. If the patient has hyperkalemia, we need to lower the potassium and do a shift, if possible, potassium shift, just to be very cautious about giving calcium because of high phosphate in the event that the patient may need dialysis. Rasburicase is available in South Africa, but extremely expensive, not available in the state sector. It's an enzyme that transforms uric acid into soluble allantoin. And so one can probably figure out that uric acid is the problem. That's where we get crystals forming the collecting tubules that causes this tumor lysis. And it is used in the management of tumor lysis syndrome. One could use something like Puricos or allopurinol, just keeping in mind that allopurinol only prevents further uric acid from being formed, and it does not transform or does not convert allantoin, does not call uric acid to allantoin. It is a xanthine oxidase inhibitor, and therefore it will stop further production of allopurinol. And that's why diuresis, fluid diuresis, is important to get rid of this excessive uric acid. And finally, if a patient, some patients may present with grade 4 tumor lysis syndrome in the form of cardiac or central nervous system complications. They may really need rapid dialysis to correct the electrolyte abnormalities. Hypercalcemia is something that a patient may present with also to you in general practice. And symptoms of this may be patients may present with renal colic or stones. They may present with bone pain. Abdominal symptoms include anorexia, constipation, abdominal pain. You may have an altered mental state. And if one does an ECG, one may find a shortened QTc interval. How do you manage this? First of all, it's fluid diuresis again to correct the hypovolemia and promote a urine output. We can add a bisphosphonate therapy in the form of permethrinate or zoledronic acid. Patients with severe renal impairment or CCF may need hemodialysis, and furosemide is not recommended unless the patient has CCF or fluid overload. Hyperviscosity. Why do patients get hyperviscosity? It's because of the severe hyperproteinemia, which causes high serum viscosity and microcirculatory problems in patients. There's a classic triad. Patients present with mucosal bleeding, either with epistaxis, vaginal or rectal bleeding, or hematuria, together with visual disturbances and an altered level of consciousness. A clue to the diagnosis is that often lab samples processing is delayed due to a high sample viscosity. And if one looks at the slide, one may notice that the patient may have rouleau on the slide. How do we manage these patients? These patients need urgent plasmapheresis together with chemotherapy and dexamethasone. And I use the word chemotherapy in inverted commas because we are moving away from chemotherapy more towards off-site targets in multiple myeloma. And finally, spinal cord compression. These patients may present with rapid loss of sensation or power of the lower limbs in the form of a neuropathy or myelopathy. They may require high doses of dexamethasone. They need to be referred to a hematologist or oncologist, potentially for radiotherapy to be initiated as soon as possible. And patients may even require surgical decompression. Okay, so how do we normally manage these patients? First of all, we fluid diurese them, prevent hemolysis, we give them allopurinol, prevent the formation of further uric acid, prevent hemolysis. Then these patients, don't forget, these patients can present with anemia, so we do need to support them with blood products as well. Therapy is usually triplet or quadruplet therapy with a combination of a proteasome inhibitor. Bortezomib has been in use for many years now, more than almost 2 decades now that it's available. And now some of the newer agents, carfilzomib, as well as carfilzomib and ixazomib, which is an oral form proteasome inhibitor, is now available for frontline therapy in multiple myeloma. The IMiDs include lenalidomide and pomalidomide. The old drug, thalidomide, is something that we still use in state. It still has anti-myeloma effect, though it has, in terms of complications and side effects, they are much more than the newer agents or the newer generation lenalidomide and pomalidomide. In terms of dexamethasone, it still forms a very important backbone of therapy in multiple myeloma. And when I spoke of quadruplet therapy, now in the first world, monoclonal antibodies are being used, directed against myeloma or clonal myeloma cells in the form of daratumumab or elotuzumab. Daratumumab is a monoclonal antibody directed against anti-CD38. Elotuzumab is a SLAMF7 antibody that's developed against it. We still use chemotherapy though. Melphalan is still the backbone of therapy, especially with autologous stem cell transplantation. And in state sector, the elderly patients, melphalan is still a very good drug to use, have very good control of disease, and we still use it. Cyclophosphamide is still used as well. Unfortunately, in the state, we don't have a lot of these drugs available. So we still use the old chemo regimens. And that's why I'm saying there's a move away from chemotherapy. We have bortezomib available. Thalidomide and lenalidomide is coming on code now. We have dexamethasone available. Unfortunately, I don't know when we will get monoclonal antibodies available in the state to treat these patients, but in the private sector, definitely it's an option, not as first-line therapy, but in relapse refractory setting. Radiotherapy is a very important aspect of the management of multiple myeloma. And the reason for this is that plasmacytomas and myeloma, clonal plasma cells are very sensitive to radiotherapy. And where do we use radiotherapy? Radiotherapy is used in patients that are presenting with, for example, with fractures, where we will target the site of fracture, patients presenting with bone. It's a very good modality of management of pain. Obviously, patients presenting with plasmacytomas, different regions causing obstruction. Radiotherapy is a rapid form of reducing the size of this mass, and it's a very important aspect of management of multiple myeloma, in addition to the chemotherapy and monoclonal and directed therapy form of treatment. Bisphosphonates are also very, very important in the management of multiple myeloma. Remember, these patients present with bony disease and lytic lesions, and so these patients, it's a backbone of therapy actually, and it has disease-modifying potential. There's 2 of them, that's pomidronate and zoledronic acid, that have been shown to be disease-modifying. Some of the other agents like ibandronate and alendronate don't have disease-modifying capabilities. And so it's also a backbone of therapy. However, it should be used in caution depending on whether the patient has renal failure or not. Autologous stem cell transplantation is established as a standard of care of management of young multiple myelomas and transplant eligible patients as a consolidation of the induction therapy. And then thereafter, patients should be put onto maintenance in the form of continuous IMiD use or PI. Some practices use proteasome inhibitors, manage the patients as maintenance. So the management is a multidisciplinary approach. It's a combination of specialists and allied services that require the team that is required to manage patients with multiple myeloma. One is hematologists, who primarily manage these patients together with oncology nurse. Radiation oncologists, as we explained earlier, play a very important role in the management of multiple myeloma. Orthopedic surgeons would attend or need to attend to pathological fractures. Don't forget the nephrologists as well, because a significant percentage of patients, almost a third of patients, they present with renal failure, renal impairment, and myeloma-related disease. The physiotherapists and occupational therapists are extremely important in terms of rehabilitation, and not forgetting our social workers and psychologists, because this can be a very physically debilitating disease and requires a lot of psychological support and social care, because a lot of these patients may have been functional and literally overnight their lives change. So just very, very briefly, we're going to discuss some of the specific managements. For example, orthopedic management. Minimally invasive surgical spinal surgery is indicated, especially when there's concomitant pathological fractures without spinal compression syndrome. And here, percutaneous kyphoplasty and vertebroplasty can be used in the management of these patients. The long limb fractures, your femurs and your humeri, it's very important. These fractures, orthopedic specialists will play a role in terms of pain relief, restoration of bone continuity, limb function, and improvement of quality of life. Radiotherapy is also a backbone of the management of bony disease, but generally this is done post-operatively. Patients presenting with solitary plasmacytoma, which is a completely different entity from multiple myeloma. It doesn't meet the CRAB criteria, it does not have the biomarkers of multiple myeloma. This is solitary plasmacytoma. It is potentially curable after surgical resection and radiotherapy. One must keep at the back of the mind that myelomatous infiltration of soft tissues usually follow internal fixation of a pathological fracture. This has been reported in the literature. Renal disease is a lot more complicated. So there are different factors that actually cause renal disease in multiple myeloma. One is myeloma-related kidney disease, which I will speak about in a little more detail in the next slide. But drugs are also notorious for causing renal impairment in patients with multiple myeloma. Cyclophosphamide, which is nephrotoxic, has been reported to cause renal impairment, and one has to watch doses when giving patients with multiple myeloma. Bisphosphonates, as I mentioned earlier, can also cause problems and cause renal impairment. And don't forget, these patients are always seeking analgesia. So NSAIDs is a big culprit in causing renal impairment. Hypovolemia is something that's a problem with patients with multiple myeloma, and therefore they require dehydration. Hypercalcemia also is a cause of renal impairment. Don't forget, these patients are prone to infections. So commonly these patients have UTIs, which contributes to the acute kidney injury. And not forgetting intravenous contrast used in radiological investigations can actually cause acute kidney injury in patients with multiple myeloma. With regard to specific myeloma-related kidney disease, there's light chain deposition disease, light chain amyloidosis, cast nephropathy, plasma cell infiltration, and nephrotic syndrome. So we'll go through this cartoon just quickly, and this is exactly what happens. We have patients with a monoclonal protein, which either damages the glomerulus or the collecting tubules, and we see it can result in a light chain deposition disease. Patients present with proteinuria, microhematuria, and may even present with renal insufficiency, varying degrees of renal insufficiency. Amyloidosis of the kidney results in more of a nephrotic picture. And don't forget cast nephropathy. You have these casts that actually cause damage to the distal tubules and results in proteinuria without albuminuria. Okay. So how do we manage patients with myeloma disease of the kidney? First of all, we need to ascertain, is there a reversible cause? Is the patient dehydrated? Does the patient have hypercalcemia? Is the patient using NSAIDs? Has the patient been subjected to IV contrast? If yes, improve after correction or removal of the offending agent. Nothing needs to be done. We can go straight on to chemotherapy thereafter. If there's no improvement, or if none of these reversible factors are present, is there any contraindication to doing a renal biopsy? If yes, then we should consider plasmapheresis. We don't do this in routine practice. Plasmapheresis is a very laborious, very labor-intensive procedure. We usually go straight on to chemotherapy. Myeloma-related kidneys, with advanced CAS or formation of or fibrosis of the kidneys, we usually go chemotherapy plus minus plasmapheresis and a trial of dialysis. Chemotherapy and plasmapheresis is offered for patients who do not have advanced CAS formation or advanced fibrosis. And if there's no underlying pathology, then one can go and look for other causes of the renal impairment. Okay, so just touching on quickly on physiotherapy, we have to be wary of lytic lesions in these patients. And active physio exercises should only be performed if myeloma bony disease is excluded to affected limbs or regions that that the physio is rehabilitating. Post-surgery, usually we use passive exercises in the first week and only muscle strengthening exercises in the second week of rehabilitation before ambulation. In terms of the psychosocial aspects, and this is something that unfortunately is really neglected, it's something that's extremely important and is absolutely essential in the management of multiple myeloma. This is a very debilitating disease, impacting on the functional state of the patient. And the patient has acute changes in terms of quality of life, and therefore they require a lot of psychological and social support with regard to their disease. Fortunately, at King Edward, we've partnered with Cancer, where they've assisted us and really have changed the management of multiple myeloma in a great way by housing our patients who are traveling from afar, as more than 150 kilometers away from our facility. We're the only facility currently treating multiple myeloma in the province. When I say we're the only facility, we don't do the transplants. They are referred to in Inkosi Alban Lutuli Hospital who do the transplants, but we are the primary specialists managing multiple myeloma that comes from the borders of our province. Patient support groups, excellent reports from the patients. Now you have patients discussing disease, helping each other through. And I must thank Cancer also for providing assistant devices to patients with disease-related morbidity, walking frames, wheelchairs. And so there's a very important aspect of the management of multiple myeloma, where in terms of psychosocial aspects that needs to be addressed in these patients. So in summary, just going quickly through those that may have joined a little late. Remember, plasma cells, clonal plasma cells arise from the lymphocytic lineage. We find that a normal plasma cell secretes polyclonal antibodies, which is usually directed against pathogens. However, pathological plasma cells produce monoclonal antibodies that are directed to self. These patients then present with recurrent infections, bony disease in the form of fractures, pathological fractures, bony pain. Patients may present with fatigue. It may be an incidental finding in 30% of patients. They may have other symptoms like nausea and vomiting. And then don't forget the criteria for the diagnosis of multiple myeloma. In addition to having clonal plasma cells, these patients have lytic lesions of the bone. They have the anemia, hypercalcemia, and kidney disease, referred to as the CRAB criteria. And we always think of myeloma in any patient with persistent, unexplained pain, generally unwell, or anemia of unknown cause. We need to perform a myeloma screen. What do? We do a full blood count, a UNE, calcium phosphate, magnesium, globulin fraction in the LFT is important pointer, serum free light chains plus minus SPEF, depending on cost and whether patients can afford this. Management, fluids and allopurinol as a generalist. Avoid complications, tumor lysis syndrome. We mentioned the use of allopurinol and fluids. Hypercalcemia, we can use bisphosphonates and fluid. Diuresis. Acute kidney injuries may need to be referred to a nephrologist for management, and hyperviscosity is an emergency that needs to be referred to a hematologist for plasmapheresis. Again, the backbone of therapy: steroids, bisphosphonates, proteasome inhibitors, IMiDs, radiotherapy, and don't forget prompt referral. Thank you very much, and these are my references. Are there any questions or comments?
Thank you very much, Dr. Hoosen, for this wonderful presentation and taking us through the pathogenesis of development of multiple myeloma, how we diagnose it and how we treat it. Just before you put that last slide, I was just saying to myself, this disease is a GP's nightmare, or any doctor's nightmare, because you find a patient presented with multiple symptoms and signs, and you don't know exactly what the problem is. But I think just last slide indicates how to quickly, I don't know how quickly it is, it means recognize the possibility that one of the differentials for when you see such a patient, it could be multiple myeloma. I remember one of my first patients in GP practice that had multiple myeloma many years ago, and was glad that we were able to get this patient to be seen by an orthopedic surgeon, but there were already lytic lesions on the vertebrae. There's a question that has been posted already. The first question is, what's the worst type of an adverse event that could occur, and also having different outcomes for such patients and poor treatment response?
Okay, so the worst type of adverse event and different outcomes. Okay, so this is actually a very, I didn't go into the detail of discussion of multiple myeloma treatment. Patients can present with end-stage renal failure. That's one of the adverse events that patients present, and it's extremely difficult to manage these patients. I think patients in private probably have especially if they're on medical aid, probably would be able to be dialyzed. But in the state sector, because of limited resources, that is one of our biggest problems, is that when a patient is diagnosed with multiple myeloma, we don't have the option of dialysis for these patients. And unfortunately, the outcomes are not very good with these patients. With regard to bony disease, again, unfortunately, we have very late referrals of these patients, and they present with neuropathy, which from my experience, if it's treated promptly, we have actually almost, I wouldn't say 100% recovery, but it's so nice to see a patient come into the clinic on a stretcher, and a few months down the line, the patient's walking again, or even if they're not walking completely, they're feeling a lot better. There's no pain. They may have some function of that is salvaged, and so that's where it becomes a bit challenging. It depends on how quickly the patients are referred to us. If the patients usually have myelopathy or neuropathy for greater than a month, the radio oncologists are reluctant to actually radiate, but I always encourage them to do it because you never know the outcomes. Beyond that, unfortunately, the outcomes are not very good, especially when you get bowel and bladder involvement. And so that would be another adverse event in patients presenting with multiple myeloma. Poor treatment response, yes, that has to do with the molecular biology of multiple myeloma. I didn't go into too much detail in the discussion, but yes, so if patients have specific mutations, your P53 mutation is one of them. That's an adverse, molecular marker. You have the translocation of 1620, translocation 414 is also considered intermediate to high risk patients. And so some of these patients don't respond very well. The non-secretory myelomas are also very difficult to treat. They don't respond very well to therapy. And then there's a specific subtype of myeloma referred to as anaplastic myeloma, which is a very aggressive form of myeloma. It usually presents as a plasmacytoma. We refer to it as anaplastic plasmacytoma. And these patients also don't respond very well to treatment, unfortunately. Okay, that was the first question, Dr. Bila. The second question you said was?
I think that was about the clinical outcomes. You've covered that. Okay. What were they? And the poor treatment response, yes.
Okay. Hypercalcemia, I see there's a question here, survival patterns of patients with multiple myeloma. Okay, so in terms of prognostication, we look at albumin, we look at beta-2 microglobulin levels. Sorry, I didn't mention this in the discussion. I thought it would have stretched out the talk even further and probably would have sort of confused the audience. So I didn't mention prognostication, but yes, these are important aspects. The old international, the prognostic score. And now molecular studies have been brought into this to describe survival patterns. So you can find patients that you have a broad spectrum of survival between, I would say, up to 9 years in patients with low-risk disease, down to as low as 3 years with high-risk disease. So unfortunately, it's a very wide spectrum. But molecular is sort of redefining this and helping us actually, sort of pick out the high-risk patients, and they are managed more aggressively. Unfortunately, we don't have a lot of the therapies that are considered, probably better in these aggressive or poor prognostic cases. So our outcomes are not too good, but in the private sector, yes, they do have access to them. They can access them depending on the medical aids. They can get access to some of these newer therapies, and then the outcomes are a lot better. The survival of multiple myeloma compared to 2 decades back to today has dramatically changed. I mean, from a disease that had a very poor prognosis. Remember, we never aim for cure in this disease. We were aiming more for disease control. So the overall survival of these patients has improved with newer therapies. Unfortunately, not the case in the state sector. There's a question on hypercalcemia. I'm not too sure what the exact question is. So hypercalcemia is a complication of multiple myeloma. Yes, we manage it with IV fluids and bisphosphonate therapy. Okay. Are there any other questions?
Yeah, it looks like there are some people who are sending questions directly to you. I don't see them. There's a question about is multiple myeloma genetic? Yeah, is it genetic?
Yeah, so well, there is, yes, there is, it is considered, there is a concept of familial, I wouldn't say familial multiple myeloma. There is some genetic link to multiple myeloma. I've had a few patients who, there was a patient who had MGUS and his sister had full-blown multiple myeloma. So there definitely is a link in the genetics of multiple myeloma. But the large majority of patients, we won't be able to find that link. So I hope that answers that question.
Okay. When you do
the chat box, Dr. Bila, are there any other questions?
Yeah, there's a question that I want for, it's just for myself. In terms of your analysis, because you spoke about Jones proteins, I used to love that a lot. About for me, it was diagnosing multiple myeloma. How much of the urine quantity what do you do in terms of?
Yeah, I know. So you're probably more used to the spot testing, of sample, but we still use the 24-hour collection of urine, and we do. It's a specific preservative that's used in the bottle. So it's not an exact amount, but it's a period of time that you need to do the collection. So it's a 24-hour collection. However, I must say that this has sort of been replaced by the serum-free light chains to a greater degree.
Okay.
And so it's something that we used to do in the past, as you alluded to, but we've moved away from that. We still use it in practice. Remember there was one slide there on the SPEP, not picking up non-secretory myelomas, light chain myelomas as well, where we do the urine to quantify, to see the amount of Benz-Jones protein greater than 0.5 grams of Benz-Jones protein is indicative of light chain myeloma. So yeah, we do use it, but not as we used to in the past.
In the past, yeah. You can see I come the old school. In terms of the patients who end up, you said that they say, sometimes the prognosis it's quite poor depending on when you diagnose the case. Those who end up with orthopedic surgeons, what's the outcome? I mean, once you see them present with lytic lesions and what?
Yeah, so it depends on the presentation. If it's a pathological fracture, the challenge that we have in the state is that there's always delays in terms of surgery. And when you have a myeloma patient lying in the ward for a very long period, then they're prone to infection. Remember, they have immune paresis, and that's where it becomes a bit of a problem. If it's something like bony pain and it's picked up incidentally, those patients have better outcomes because, I mean, you got a patient with back pain that's coming repeatedly to a practice, and they refer to an orthopedic surgeon. He does an X-ray and he says, there's lytic lesions here. Let me do an SPEP or let me do a serum-free light chain, and he points towards multiple myeloma. The outcomes in those patients may be a lot better because it's picked up earlier. So it just depends on the presentation to the specialist, the orthopedic surgeon. If there's spinal involvement and there's paraparesis, generally the problem there is the performance status of the patient. If they have poor ECOG performance status, they don't do very well. Unfortunately, in the state, we have delays in referral to us. So these patients that have paraparesis end up coming to us with bed sores, and that can be quite a nightmare to manage, because imagine giving chemotherapy to a patient with open wounds and the risk of infection, the outcomes are not very good. Yeah.
Yeah, sure. This could be the last question that you have. There are two actually. There's one about any psychosocial support organization you can use to empower the relatives on how to support the loved ones. But maybe Cancer Association, if I'm not sure if Lorraine is still there, someone who can also chip in there. And the other one related to that, in terms of rehabilitation, how soon do you involve both the physiotherapists and occupational therapists as part of the treatment regime?
Okay, that's a very good question, actually. With regard to the first question, as I mentioned, we are fortunate, that we've got Cancer Association that supports us in a great way, and I'm sure they have branches throughout the country in the Gauteng province as well. So I'm sure if you get hold of Sister Lorraine, she may be able to direct you to someone because they have very, very good support. They've started off patient support groups in our clinic, which is excellent. We have patients that are obviously now well educated. You have support for family. They've been taught how to manage these patients, and just being able to guide them along to management of their family or relatives. The second question was with regard to
physiotherapy and OT.
Rehabilitation. Yeah. Okay, so that's a very good question because I've seen this in the ward. You got a patient that's lying in the bed and someone tries to lift the arm, and next thing you know, you got a fractured humerus. I had a very unfortunate incident. A patient of mine who had a plasmacytoma, solitary plasmacytoma of the pelvis, and it was a massive plasmacytoma, completely destroying the hemipelvis, and he was not amenable to surgery. So what we had to do for him, we had to offer him radiation therapy, and he had a fairly good quality of life for about 3 years because he was in extreme pain. And then he relapsed. He developed full-blown multiple myeloma about 3 years later, and it is a risk factor if you have a solitary plasmacytoma that you could potentially develop, multiple myeloma at a later stage or transform to it. And his wife, she tried to assist him one day, and she actually fractured his femur. So yes, with regard to physiotherapy, it's not something that we would involve very early in the management of multiple myeloma. You would like to treat the disease, definitely get better control. And especially if you're trying to rehabilitate specific areas, like for example, you're trying to, you need orthopedics to fixate, a femur. You can't just start rehabilitating it because that bone is brittle, and you'll have to allow it to heal. So there's always a delay and lag in terms of rehabilitation. We normally tend to find by about 2 or 3 cycles of chemotherapy together with a bit of radiation, these patients then get into a better condition, and we can then start initiating. So it's a very gradual process, I agree. Obviously, in a setting where you have, you can treat more aggressively with radiation and that type of thing, you could potentially start it earlier, but I wouldn't start it in the first or second cycle of a patient's therapy, depending on what type of rehabilitation the patient may require.
Yeah. Okay, I thought this will be the very last question. William as well wants to know, have you as Dr. Hoosen exhausted avenues, state government in assisting multiple myeloma patients since many people are unemployed? I don't know if you understand the question.
Okay, so when you mean exhausted avenues in state government in assisting multiple patients, any people are unemployed. Look, here, we have chemotherapeutics that are available to us, right? I know it's not ideal when you hear of the outcomes with newer therapies, but we have been getting it into management of, like thalidomide was not available previously. Now the national PTC has agreed to us using it. Now of recent, we had a meeting where lenalidomide is going to be brought in. Bortezomib has been brought into the management. So yes, we are getting access, and we've exhausted those avenues to a certain degree. But I think there's a limitation in terms of how much can be spent because these drugs are very expensive. And remember, these are very rare diseases, and the outcomes are not the best. So you have to look at both the benefit and the harm. I mean, you have a patient with diabetes or hypertension, and you've got hundreds of thousands of patients with this disease. So can you really justify spending 100,000 Rand on one patient when you could use that money to manage many patients with other diseases that are not necessarily curable, but definitely manageable. So it's always an ethical question. Yes, it's a bit of a difficult one. We have engaged with, so we have, we have trials available. So that's when patients can benefit from neurotherapies. So those are the avenues we can sort of try and, exhaust. But unfortunately, those are depending on the availability of those trials. And yes, the patient's unemployed. So it's a bit of a tough one. It's very difficult. We have, as we say, we've got patients coming from very, very far. They travel almost overnight to get to my clinic. Some of them leaving in the afternoon to jump onto a bus in the evening at base. I mean, imagine traveling 5, 6, 7 hours on a bus, stopping hospital to hospital. Yes, so they do come to us and they are unemployed. So we do have that. We've tried to so that's where cancer comes in. Instead of a patient having to travel up and down, we normally keep them in cancer home, provided they are able to take care of themselves. We are hoping, I don't know if Sister Lorraine is on, that we can get a nursing sister there so she can help those patients who can't fend for themselves or like have minimal, help. So yes, we've sort of exhausted whatever we could, but there's still a lot that can be done.
Yeah, definitely. And you've been one of the few, I think, tertiary hospitals in KZN.
Yeah. So there's 3 tertiary hospitals in KZN. Unfortunately, and there's 1 quaternary hospital. So Nkosi Albert Luthuli is our quaternary hospital. They do our transplants for myeloma patients, and they treat acute leukemias, and they do all the allogeneic stem cell transplantations. So they're very specific niche management of patients. And here at King Edward, we're the only tertiary center that are actively managing myeloma. We've got a center in Pietermaritzburg at Gray's Hospital that manages, but they do very, very little in terms of treatment. They do more supportive management, workup of patients and then referral to us. There is a hematologist that has been recently appointed there, I believe. So I'm hoping they can grow that service. And then there's Ngwelezan in the north, in Richards Bay, in Pangeni region. There's another tertiary hospital, but they don't have a hematologist there. So that's something that we are working towards. We are training more hematologists, and let's hope they can go out to these peripheral tertiary centers where we can start managing these patients, where the treatment should be available closer home than having to travel all the way to King Edward in Durban.
Yeah, definitely. Yeah. Now, I think we have taken much of your time already, Dr. Hoosen. Just leaves much for me to say thank you very much for availing yourself and taking your time all the way. We know that it's on Zoom, but in KZN, it's not often that we get presentations from that part of the world. But we are thankful and grateful for you for taking your time and presenting this topic. It was a very complex topic and in so simple way. Quite a number of people are quite happy with the presentation. Thanks for an excellent presentation, I say, and also a concise presentation. Also, we should thank the Department of Hematology. I think the professor who, when we reached out, they agreed that we should ask you to do that presentation. And also Cancer Association for partnering with us this evening to make sure that we have this presentation. And also, they're quite available to all those who wish to get in touch with Cancer Association to assist those patients that they may need assistance with, not only with multiple myeloma, but also other cancers. And to thanks all colleagues who joined us this evening and always for being with us every week, and those who joined us for the first time. Thank you very much for joining this webinar presented by Clinics Health Group. And also wish to thank the support team, Kamu, doing the presentations and making sure that we are well connected, and the team that I work with, marketing team from Clinics Health Group, for making sure that we have good presentations and we've got the support that we need. And for the management of Clinics Health Group for allowing us to host these webinars on a weekly basis. And we hope to connect with you again, colleagues, next week as we continue with our weekly webinars, and have a good evening. Thank you very much.
Thank you.